Yes, ma'am.
Okay, I'm starting the timer. Right, timer is on, and here is your question. Right, so if you've read and understood, kindly tell me, how
Yes,
are
ma'am.
you going to manage this patient?
Uh, Management of this patient will follow according to ABCD protocol.
Yes?
First of all, positioning of the patient. We are going to position the patient with the head tilted, head and tilted up at 20 to 30 degrees to encourage cerebral venous drainage, and also loosen if there is any tracheal tapes. And we should avoid immobilizing the cervical spine with a hard collar. Rather, we can use sandbags and tapes. And then after that, there is for reducing the cerebral edema, we can use there is fluid restriction. We'll use mannitol, intravenous mannitol at a dose of 0.25 to 1 milligram per 1 gram per kg over 30 minutes, and this will rapidly reduce the raised intracranial pressure. There is also another one which we can use is loop diuretics, and we have to ensure that the serum sodium is maintained at a level of 140 to 145 millimole per liter. After that, then we have to ensure controlled ventilation to keeping the partial pressure of carbon dioxide within 4 to 4.5 kilopascals.
Okay, I have to
Then
interrupt you. Patient has
yes,
Glasgow Coma Scale 8 right now. What would you do? What would be your immediate
uh, I would go
management?
for a CT scan of the head.
Is that all?
And also, I would
What are
admit the
the, yes,
patient in the
indications? Yes, yes.
ITU
And
and intubate the patient, ma'am.
very good. And a call to
And
neurosurgery.
and call the neurosurgeon and the critical care management team.
Okay.
Yes, ma'am.
Just suppose you've done the imaging and this is what you got. How would you read it?
This is a CT scan of the head with contrast, showing uh, showing a biconvex or lenticular hyperdense shadow with effacement of the ventricles and midline shift.
And what is the,
This
okay,
is a showing right-sided extradural hematoma.
all right, okay. What is the normal intracranial pressure?
Normal intracranial pressure is 7 to 15 millimeter of mercury, or 5 to 20 centimeter of
How
water.
can you measure it? What are the ways?
There are different ways to measure. Some are invasive and some are non-invasive.
Very good.
Invasive are
Tell
such
me,
as
please.
external ventricular drain, or there is intraparenchymal no intraparenchymal probe
Transducer, yes.
or
Okay.
a and subdural catheter,
Yes.
and non-invasive are such as transcranial Doppler, which measures the middle cerebral artery velocity and derives a pulsatility index that will correlate with the intracranial pressure.
Can you tell me if you can do the lumbar puncture in this condition in this patient?
No, ma'am, because
Why?
there is a risk of herniation and coning of the
Very
brain.
good. Can you tell me what comprises Cushing triad?
Cushing triad is comprised of systolic hypertension
Yes.
with bradycardia and
Bradycardia
irregular
missing.
respiratory pattern.
Yes. Yes. Good. How would you differentiate it from Cushing reflex?
Cushing reflex is mixed vagal and sympathetic stimulation due to raised intracranial pressure, and this results in a hypertension that ensures that the cerebral perfusion pressure is maintained, and also there is bradycardia.
Good. This patient, before patient dozed off, patient had a normal Glasgow Coma Scale 15, and then had some amnesic event. What are they called? Or what is
A
lucid
lucid
interval?
interval.
Yes. What is
Yes, ma'am.
lucid interval?
Lucid interval is a temporary improvement in the patient's condition following a traumatic brain injury, after which there is rapid decline in the patient's consciousness. During this time, the blood from the middle meningeal artery seeps into the extradural spaces, resulting in raised intracranial pressure and cerebral edema.
Can you tell me the pathophysiology of increased intracranial pressure? What happens?
Uh, the uh, do, the pathophysiology of raised intracranial pressure follows the Monroe-Kelly doctrine regime, where
Very good. Yes.
the hypothesis is that the skull is a fixed box comprising of three components: the brain tissue, the blood, and the cerebral spinal fluid in an equilibrium. Any increase in either of the component will result in a compensatory decrease in the other. This is maintained to maintain the intracranial pressure. However, this will be maintained until the ICP rises up to 25 millimeter of mercury, beyond which even a small rise in the volume of brain tissue will cause rapid rise in the intracranial pressure, leading to
Very good.
brain herniation and other features of
Very
reduced
good.
intracranial pressure.
Okay. This patient first had Glasgow Coma Scale 15, and then it decreased to 8. How do you
8.
calculate Glasgow Coma Scale? What does it comprise of?
Glasgow Coma Scale, it comprises of three components:
Yes.
eye move eye, motor move eye response, motor movement, and verbal response. We
Yes.
gave a total score of 15,
Yes.
of which eye response comprises of 4 points,
Yes.
verbal 5 points, and motor 6 points. Ma'am, should I tell the
You said
whole
at
thing?
Glasgow Coma Scale 8, you will go ahead and you will intubate the patient. Why?
Because sorry, ma'am.
Yes. You
It
know
is
it.
an indication for the intubation for this patient, because the
Yes.
patient
Why?
will be because the first of all, Glasgow, with a scale of Glasgow coma less than 8, the patient might not be able to maintain or protect their own airway, and also won't be able to there could be aspiration because the patient won't be able to cannot
So
swallow
what
own
will happen?
secretion.
Think tissue
There
hypoxia,
would be
and then what are
tissue
the risk
hypoxia.
factors? Yes. Tell me all the sequelae that you can think of. What will happen when you're not patient is not able to ventilate? Patient is a case of head injury, and patient has Glasgow
Yes.
Coma Scale 8. So tell me all the
So-
sequelae, all the complications that can occur
Alright.
or that can take place if you will not intubate at that time.
Okay, if the patient, there would be aspiration, and also the patient, because there would be uh, uh, inadequate ventilation,
Very
and
good.
also
Yes.
because there would be already a raised intracranial pressure, which would
Yes.
result in a herniation, and this could cause a compression over the respiratory center,
Very
and
good. Yes.
and would result in type 2 respiratory failure.
Okay.
Because carbon dioxide would be there would be hypercarbia, so there would be carbon dioxide retained within the body.
Yes.
Yeah. So yeah, basically after that there would be death of the patient because of respiratory failure, hypoxia and respiratory failure.
Good. Okay. Can you tell me if you have to do a borehole surgery or procedure? So what are the layers that you will go through?
Okay, first skin, then subcutaneous tissue,
Yes.
then a temporal fascia, then temporalis muscle, then after temporal periosteum, then outer and inner table, then is the then dura mater, actinate mater, pyometer layers, and then the
Yeah.
yeah,
Brains.
then the middle meninge.
Yes.
Then there was a middle meningeal artery. Yes, middle meningeal artery. Yes, ma'am. 9 years. Yeah.
Right. You did tell me who would you involve. Okay. This patient, right, when because of intracranial pressure increase, it can have a dilated pupil. Why? What causes
Okay,
dilated
so
pupil? Yes.
because of the raised intracranial pressure, there is compression, there is herniation due to the transtentorial herniation will cause compression over the oculomotor nerve. The oculomotor nerve carries parasympathetic fibers. Because of the compression, there would be unopposed sympathetic activity resulting in dilatation of the pupil.
Very good. Excellent. And you did tell me who would you involve in the management of this
We would
patient?
involve a neurosurgeon and also cardiologist and critical care team, of course, with ITU
Very
specialist.
Good. Very good. Excellent. Right. Yes, Dr. Ishfaq, you have a question? Want to give feedback? Good.
Thank you, ma'am.
Yes. Yes, please.
I
Dr.
keep
Abhishek.
Yeah,
Dr. Ulfat, you did great actually. I have a question for you. Like, why would you involve a cardiologist, not an anesthetist?
Didn't she say anesthetic before?
Oh, sorry. I would also involve an anesthetist, but also a cardiologist because, ma'am, could I see the question again, please?
Yes, please.
Because the patient is okay, a cardiologist because of the pressure hypertension development that the patient could have, and also
That is the consequence of
No.
raised intracranial pressure.
Yes, there is no need of course.
There is no need for cardiologist. If you would have
Whatever
said
you can define,
neurosurgeon,
just say it. I will not involve. Okay. Yeah.
yeah.
okay, fine.
But like
All
if
right.
you would have
Just
said
tell me.
neurosurgeon, I didn't even realize he said that. I'm sitting asking. And then I was like,
Yes.
all right.
Yes,
Yes.
ma'am.
And
Okay.
in burr hole, I think after penetrating the inner table, will reach the hematoma because it is extradural.
Yes.
Yeah.
Yes,
Right?
yes.
Yes.
Okay.
Yes.
Okay.
Just after inner table, you will reach the hematoma.
All right. Up to the inner table. Okay.
Yeah.
yeah.
Thank you, doctor.
Yes. Yes, Dr. Mohammed. Any question or feedback? Yeah.
Yeah, can be added that.
Yeah.
Yes.
Indication
What
of
are the
CT
other
scan,
indications of
head
CT
injury.
scan?
According to the Canadian head CT scan for a head injury patient, they're high risk and moderate risk. patients are categorized according to high risk and moderate risk. According to the high risk, Glasgow Coma score less than 15 at 2 hours at 2 hours from the injury. Then,
Look,
if there is
he's correcting
suspected
you according
open
to NICE guidelines. It's UK's exam.
Yeah.
You must always
what I
mention
sorry.
NICE guidelines.
Nice guideline. Yes, sorry. Nice
That's
guideline.
okay. We're correcting. We're practicing.
Yes, ma'am. So according to NICE guideline, there is high risk criteria patients and moderate risk. High risk are patients, any Glasgow Coma score less than 15 from 2 hours of injury. Then if there is any open or depressed skull fracture, if there is any signs of basal fracture, that is, if there's battle sign, raccoon sign, or CSF autouria, rhinorrhea, and also if there is more than or equal to 2 episodes of vomiting, and if age is more than or equal to 65 years, and any head injury in case of patients taking anticoagulation. And also in case of then moderate, for moderate risk criteria is any patients with amnesia for more than or equal to 30 minutes from the event, and dangerous mechanism of injury such as pedestrian hit by a motor vehicle, or occupant ejected from a motor vehicle, or fall from height more than 3 feet or more than 5 stays.
Good. Yes, please.
Yeah.
Yes, there is a question about
Yeah.
CPP.
Cerebral perfusion pressure is actually the difference between the mean arterial pressure and the intracranial pressure, and it normally should be maintained at 70 millimeter of mercury, and it is usually disrupted when the autoregulation of the mean arterial pressure is disrupted. Extremes of age, yes,
Yeah.
okay. Extremes of age.
I have a question for Dr. Ulfat, ma'am.
Yes, please, go ahead.
Dr.
Dr.
Ulfat, can you
Mohammed
please?
Al-Tahir, if you have a patient you want to leave, then I can save it for tomorrow. You can decide and tell me. Yes, please, Dr. Abhishek, I'm sorry.
Yeah, Dr. Ulfat, can you please tell us the pathophysiology of Cushing reflex? How the mixed vagal and sympathetic stimulation cause that?
Okay.
Stressing the girl.
Okay.
I asked her the difference.
No, I asked it because, ma'am, in the
No,
anatomy session,
it is important.
it's
It is
a
important.
question. It's a
Yes,
question in
yes,
the anatomy
I
portion.
know.
Why it is
It can
raised?
be asked.
Yeah.
It can be asked. Go ahead,
Yes.
please, Dr. Ulfat. It's for your own good.
Yes,
I used
ma'am,
to
of
do
course.
this like with Dr. Meena, and then she passed on the first attempt. So this is good. Like
Okay.
it's a blessing for you. Yes, please.
Try it.
Yeah.
A Cushing reflex, right?
Yes.
So there is
Pathophysiology.
sympathetic activity and vagal stimulation will cause the. Okay, I'm sorry. You will have to say
Oh,
it.
no,
I'm sorry.
don't give up, please.
Mixed vagal.
Anyone,
and
Dr. Mohammed, maybe?
Yeah, can be. Hello?
Yes, yes. We're
Yes.
listening.
Yeah, can be added easy equation to
Okay.
calculate
Oh, the network.
If there is raised intracranial pressure,
Yeah.
so there would be
This network is not good. I can't hear
the chemoreceptors will detect this because there's raised intracranial pressure. So yeah.
Okay, let me say it. Okay, ma'am, I'm just telling it, okay?
Yes, please.
Actually, whenever this kind of thing occurs, there will be raised ICP. So cerebral perfusion pressure is equal to mean arterial pressure minus the intracranial pressure, right?
Intracranial pressure, yeah.
Raised ICP exceeding the mean arterial pressure, there will be activation of cerebral ischemic response in the hypothalamus. And the hypothalamus will increase the sympathetic activity of the body. And due to this sympathetic activation, there will be increased force of contraction, heart rate, and also systemic vascular resistance. That will cause hypertension.
Resulting in hypertension.
Whenever this hypertension occurs, the baroreceptor will sense this, and there will be increased firing from the baroreceptor centers. Okay, the carotid sinus and aortic arch, and that will be perceived by the vasomotor center of the brain. So when there will be increased firing from the vasomotor center, and that vasomotor center will increase the vagal tone. That is the parasympathetic one. Due to this increased vagal tone, there will be bradycardia. Am I clear?
Okay. Yes. Yes,
So
Dr.
actually, this is the
Abhishek.
mechanism of this Cushing reflex. There is a question in the anatomy. That's why I have just letting you know.
Yes.
Oh, no, thank you. Thank you so much.
How
Yes.
do you calculate CPP? CPP depends on what factors?
Mean arterial pressure and the intracranial pressure difference.
Okay, difference of mean arterial pressure.
What is the calculation of mean arterial pressure?
Mean arterial pressure is diastolic blood pressure plus 1/3 of pulse pressure.
Yes, yes, Dr. Mohammed.
Yes, can be added a more easy equation to calculate the ICP as 2 diastole plus systole divided on 3. More easy question to calculate the ICP.
Okay. There was one question someone wanted to discuss ABGs. I have seen it somewhere here. Right.
About ABG changes, Dr. Rajiv.
ABGs, yes. There was, yes.
So this would be respiratory, this wouldn't be metabolic, it would be respiratory acidosis.
Okay, why?
Because the patient will go into type 2 respiratory failure because of the hypercapnia. So raised partial pressure of carbon dioxide will cause decrease in the pH without any compensation with the bicarbonate now, right?
Good, good, yes.
There will be compensation, but late.
Not now. Yeah, later.
Late,
yes.
late.
Compensation.
Yes.
Not right away, but then yes, eventually it has to.
Yes, ma'am.
Right, good. Should we move on?
Yes, ma'am.
Yes, ma'am.